Now, today marks World Competition Day, and the theme is competition policy and access to healthcare. The COVID-19 pandemic laid bare the inequalities, especially in healthcare, still present across the world, particularly in South Africa. Tembinkosi Bonakele is the Competition Commission Commissioner. He joins us via Skype now for more on this. Thank you very much for your time this afternoon. So how would we characterize South Africa's provision of universal access to healthcare?
Thanks very much for this. South Africa, of course, has a dual system of providing healthcare through the public sector, which still provides for the majority of people, roughly 85% of the population, access healthcare through the public sector. The remaining 15% are people with medical aid schemes, and they tend to be channeled through the private sector. The anomaly of South Africa is that the spending is the other way around. The 15% gets 85% roughly of the spend for healthcare, and the 85%, which is dependent on the public sector, roughly gets about 15%. So we're seeing huge inequalities in access, especially on the quality of access. We're also seeing pricing playing a huge role in discouraging people from using the public sector, and of course the high cost of medical aid schemes. So we are spending on par, more or less, with many countries, even in the West, in terms of our GDP size, but there is massive inequality as well as sometimes poor outcomes.
In enters the Competition Commission with the competition policy, aiming to do what exactly in terms of bridging the gap? That's a rather gaping hole between the two.
Correct. I mean, part of what we have done, we've done a market inquiry a couple of years ago into the sector. The firstly is to try and demystify this sector, because a lot of people, you would appreciate, when they go to get a service, they will start with the GP. That's probably the last choice they will make, which GP they go to. After that, there is complete information asymmetry. The GP will decide which specialist, if they have to be referred to, must they go to, and that specialist will most probably be based on a particular hospital. The customer, that is the patient, will not be able to choose any service provider, or even be informed to make a choice about a particular procedure. So we're seeing, for example, in South Africa, that in private hospitals, you're seeing a lot of birth by way of Caesar, whilst in fact in the majority of public hospitals you see natural birth. That's because women in the private sector really are not in a position to choose. The medical professionals themselves choose. So the first thing is address the information asymmetry, empower the patients as well as the GPs with information, and then try and deal with costs. So deal with costs by way of regulating some of the medical procedures, because there's no competition that can address that problem. So you have to deal with it by regulation, and also have an entry-level medical aid scheme. This is what we have recommended, a standardized medical aid scheme. We've done this with banking, for example. Many years ago, we recommended that there be a standard banking account for people who are in pension, poor people who could access, that is similarly priced and that is transparently priced. And we think you can do the same with medical aid schemes.
A myriad of problems that you've highlighted, but also you're offering a solution. So let's talk about this entry-level medical aid scheme. Why has it taken us so long to enforce this?
You see, this report coincided also with a move by government to introduce NHI, and there was considerable debate about what will be the remaining what role will the remaining medical schemes play in that environment where we have a single insurance and everybody would have access. And so that debate has now led to an acceptance that there would be a medical scheme of sorts, but there is still a question whether if you have the NHI, you will still need to have this medical aid scheme cover that we have proposed. We are worried, of course, that the debate around NHI is taking too long, and it seems to us is going to take longer to implement. We have been hugely disrupted, of course, by COVID-19 as well. So some of these debates have somewhat been deprioritized. But we think that there is certainly commonality of approach, whether you look at it as an access driven through NHI or through this standardized medical aid scheme.
Is this all in vain? Because at the end of the day, somebody does benefit from the status quo being the same. To your point or to your example of expectant mothers between private and public health care, if you will, and the costs associated with it and the information associated with it, or the lack thereof, for people who are in public hospitals. Will we ever see a change? Because this does benefit, you know, whoever is making money out of this.
Yes, the private sector will always want to make money. So as long as this public good, healthcare, is provided through private health care, you would expect that people would want to make a profit. This is where there is a responsibility on the part of government, which bears the primary responsibility to ensure that we have access to healthcare in terms of the constitution. So where the government is not providing the service, it bears the responsibility to regulate the market in such a way that the constitutional right of access is realized. And this is what we are nudging government towards.
I guess this is not in your scope, but also it goes with service, as you mentioned, right? So when you go to public health care facilities, sometimes the treatment that you get is appalling, whereas when you pay for it, of course, you're going to be treated much better because you are forking something out. When it comes to costs and pricing, how far has the Competition Commission gone in terms of trying to bridge the gap there to make sure that there's better access?
I think when it comes to pricing, we now have gotten everybody to understand that there is a problem. So there have been price increases over years which were far above inflation, and there had always been disputes about whether this was fair, there could be justification for this. I think now we have arrived at a point where everybody, including the private providers, have accepted that there is a pricing problem. Where I think we might part ways is what to do about it. We have recommended that the only way to address that, if you're going to have a procedure at a private hospital, you must have a sense of how much that procedure is going to be. And we think that the best way to achieve that is through a regulated price. So there needs to be a regulatory framework that creates a body that will determine pricing, not only in the public sector, but also in the private sector. We think it's the only way that can work. In other words, we have no hope that competition, as it happens in other sectors, will be able to lead to competitive prices. There is a failure in the market, and therefore you need a regulatory intervention.
You mentioned the NHI. There are countries where it's working and there's some countries where it's not working so well. Where can we pick good things where we've seen things work in terms of other countries and what other people have done when we compare apples with apples? Countries like ourselves, so-called developing countries.
Yeah, there is of course a challenge with healthcare around the world. I mean, the Obamacare in the U.S. was aimed in part to also address a similar problem that even the richest country in the world seem to be grappling with. So I'm afraid you're not going to find a perfect system, even in developed countries, let alone developing ones. We see that many countries, though, have been able to kind of have their private sector working hand in hand with the public sector, where you have private participation. So we see this in the UK. I think is a very good example of a national health insurance system that seems to be working. I'm not saying it's without problems, but there you're seeing that the quality is possible for the public sector to have a quality of service that will be more or less on par with the private sector. The private sector in South Africa have been found wanting when it comes to over-servicing. So we're seeing that in many developing countries where people are spending less, are achieving similar outcomes as us. And this is because we are spending too much money for a very little return, if I may use that language. So we're seeing that even in developing countries, there are lessons we can learn. Countries like India, for example, are able to deliver healthcare at a fraction of a cost that we are doing in South Africa. And that's why you see people flying into India for medical care. And so we think that one of the critical things is we don't just have to praise the private sector. And of course, there are areas where it is good, but I think that we're seeing a lot of inefficiencies there as well. And this has been exposed during COVID-19, that it doesn't necessarily mean that you are in a very nice environment, that the clinical care that you are getting there is necessarily the best. And that's what we need to address, poor outcomes.
Indeed, interesting. Thank you very much. Tembinkosi Bonakele is the Competition Commission Commissioner.